Thank you everybody for coming. I am here to talk about peer review as a department tool. If you are here because you are interested in New England Journal of Medicine type peer review for papers, that's not this. I give you permission to leave. The rest of you, thank you for sticking around for a late lecture today. So my name is Grosso. I'm faculty at the University Hospital's Cleveland Medical Center. And I'm going to talk about teaching the toggle, peer review as a metacognitive educational tool. I have no disclosures. By the end of the session, I hope that you can describe a novel peer review model that focuses on teaching metacognition. I want you to be able to use that peer review model to improve your entire department's clinical metacognitive skills at the bedside. And I want you to recognize the value in teaching the toggle between System 1 and System 2 thinking via peer review. So there's some caveats here. It's only a 20-minute didactic, so I don't have time to talk about the logistics of how we made this change, which happened over 4 years at our department. But this has my resources and has some of the logistic tools that might help you make that change. I'm also happy to discuss via email afterwards. But first, I'm just going to tell the story why I'm talking about this, why I'm up here. And I'm going to try to connect two seemingly kind of separate concepts of metacognition and peer review. But the reason why I'm up here talking about the connection between the two of them is because I spend a lot of time thinking as an early faculty member about how the critical case review I did as a chief and as a quality resident, as a fourth-year resident, made me a better clinician at the bedside. I spent a lot of time thinking about why I picked up on a crypto and immune-suppressed headache one of my first shifts as an attending, and it was because I knew when to move to that type 2 thinking. I was also named the peer review director when I showed up with a really young department and thought about how can I extrapolate that learning to all of my department members, faculty, residents, APPs. How can they all benefit from that same learning? So that's how we got to the peer review concept that we use today. So let's do some definitions, and then we'll get into the new peer review model. So traditional peer review is critical appraisal of care by peers. Sometimes this senior leadership in a closed room, sometimes it's more of a mixed group of people, but it tends to be, a lot of senior leadership appraising the care of their peers. It has a lot of hindsight, but has varying levels of context, right? How much we allow the providers who are putting in the time at the work at the bedside, how much we let them input into the peer review process varies by department. And it's sold as non-punitive, but having been on the receiving end of a lot of peer review emails, not a lot, a few peer review emails as a resident, it rarely felt that way. So let's jump and define metacognition. It's the awareness and understanding of one's own thought process, and it's been popularized by this book, Thinking Fast and Slow. It's about 600 pages. The first 100 are worth reading. Don't keep reading after that, I promise. But what this book popularized was this cognitive debiasing theory, which is actually also referred to as dual process theory. This is super busy. People make their entire careers out of this. Please don't memorize it. It's not worth it. However, what we are going to focus on is type 1 and type 2 processes. I'm going to go through an example in a sec, so this should reinforce it, but I just want to do some definitions before my example. So a type 1 process is fast. It's heuristics-based, and you can do multiple at the same time. Notice there's multiple lines here. This is also where cognitive errors happen because it's fast and heuristics-based. So this is cognitive errors, cognitive dispositions to respond, cognitive biases. We call them a bunch of different things. They all mean the same thing. And that's a predictable deviation from rationality, right? So it is, and notice it's predictable, and that's the key to some of this learning. Type 2 processes are slow, they're deliberate. Notice there's only one, and we're going to talk about that and why that's key. You can only do one type 2 process at a time. And they're under your conscious control, and they're much, much less error prone than type 1. So let's talk about why the emergency department in general is prone to these type of cognitive errors. This is an actual case that happened to me and that I reflected upon and thought this is why we make mistakes in the emergency department. So to just orient you to the example, me, type 2 process is going to be in purple, type 1 process will be in green. So let's say it's the beginning of a shift. I had a patient in bed 15, an elderly gentleman with nausea and vomiting. I had time to run a differential with my resident. We were running through all the things that might make an elderly gentleman vomit. However, then we got a call that we had a female en route for an MVC. Her vitals are normal, but she's unresponsive. You know, I've been doing this for a little while now, 4 years. I can say that I can run a differential for this patient in a type 1 process. I have a heuristics built for an unresponsive MVC, right? I also can usually do a primary and secondary survey without much thought. I can even manage the most challenging of trauma surgeons in a type 1 process, right? I don't really get all worked up about that anymore. Used to, but I don't anymore. So I can do my crew resource management in a type 1 process. However, then they jump in and say, hey, this is a low-speed MVC, and now she's awake but is not moving her right side. Now my type 2 process has to be in the complicated, has to move to this differential because this does not fit in my normal heuristics anymore. So I have to start thinking type 2 about this patient, and I stop thinking type 2 about this patient. I just think gastro, gave him some Zofran and some normal saline, went to the trauma. I examine the patient. She is what is very obviously a left MCA stroke on my exam. So I then can transition this back to type 1. I can do an NIH stroke scale as a type 1 process. I don't need to type 2 think about that. However, if anyone's trying to manage a stroke team and a trauma team at the same time, that is a type 2 process, right? One literally stops bleeding for a living, and I think the other one tries to make people bleed for a living. So making the two of them work together and making sure everybody is on the same page has to be a type 2 process. But then they jump in with, by the way, she's only 22, and I look at her and I know her. She's one of our nurses. So now my type 2 process is in the emotion of the case. I cannot screw this up. I know this person, she's 22 and having a stroke. And because of that, the thing that should have been done in type 2, this complicated crew resource management, was done poorly. Someone in the room knew she was on Coumadin, I did not, right? And when she got TPA, that communication was not transmitted, and there's a cognitive error made because I was having to sit in my type 2 emotion instead of being able to do this in type 2. I also made a cognitive error at the beginning in that this human was a STEMI. It was a bad day for me. So this person also, because I wasn't able to give him the type 2 thought he deserved, I made an error there too. Which is just an example of why emergency medicine in particular is prone to bias, right? We sit in type 1 most of the time, and we can only do one type 2 at a time, even if our patients deserve that type 2 thinking that we should be doing about them. We just can't, it's not possible. So let's reframe the concept of peer review within this metacognitive lens. I'm gonna refer to it as peer review 2.0 from now on. So the first thing that we changed about our department peer review was we are over-triaging. And you'll see the importance of this in a second. But we over-triage, and we really ask ourselves about any case that comes through chief review, comes through past reports, anonymous reporting systems, self-referrals. We ask ourselves, did the provider contribute significantly to the outcome of this case? If it's yes, that patient's case goes to peer review. So we end up doing like 7 to 10 cases a month. It's an open meeting. It's all providers are invited, including learners. Residents are required to go once a year. And then during intern orientation, we orient them to the process, and then they attend their first meeting in July. So they have a kind of a guided meeting for their first time to really understand the process. We close the session at the end and have attendings only in order to have some difficult conversations if there's conversations attendings aren't comfortable having in front of residents given the relationship. But I can tell you that after 4 years of doing this, those conversations aren't that different, actually. We do some scoring in that second session, that closed session for like OPPE, FPPE purposes, but the bulk of the discussion happens in the open session in which we invite every provider. We also make it worth CME so that we can bring providers into the meeting. So our first kind of piece of the puzzle of our new peer review is that we really aim to have it raise all boats, and we open the meeting to all providers and learners. The other advantage of this is that sometimes when you are being critiqued, you do not have the bandwidth to then learn from that. However, if you can watch someone else do the same thing, you may be able to learn from their case. And so having more cases for that to happen just gives people more of an opportunity. Our first metacognitive theory that changed how we do peer review is that repetitive processing using type 2 processes may allow those processes to transition to type 1, which I renamed type 2 practice makes type 1 perfect, right? Or practice makes perfect. This is laid out in dual process theory here, and that you can do, if you repeat type 2 process enough, you can recognize patterns and turn them into less error-prone type 1 processes. So when we sit and think about what peer review is, it is the ultimate type 2 process, right? It is slow, it is deliberate, it is, has the benefit of hindsight. So we ask our junior faculty to be case reviewers in order to push them to do this over and over again about difficult high-risk cases so that they can recognize patterns and build better type 1 processes early in their career. So the second piece of the puzzle is that practice makes perfect. We focus on junior faculty participation. Senior faculty come to the meeting, but they are not asked to review cases. Junior faculty are asked to do that type 2 thinking about a case and then present the results of their review to the crowd. The second metacognitive theory is one can toggle to type 2 processes and they override type 1 process. And this is really teaching our providers how to toggle. So this is illustrated here. You can consciously override this type 1 process and go to a type 2 process. We do this by asking our providers, everybody whose case gets sent to peer review fills out a cognitive autopsy, and we ask them to focus on that moment where a cognitive error was made. We ask them to focus on the moment where they should have toggled out of that error-prone type 1 thinking and into a less error-prone type 2 thinking. And we talk about it at the meeting. We say the words, and we really try to bring up all the reasons that we may have made errors during the case. The hope being that the next time that same provider or any provider is in the room, who's in the room listening, is approaching that same error-prone situation, they can say, nope, I have to stop and type 2 think about this. I think the way that we know this is working in our department is the number of times when you walk around our department now and hear the words, I'm anchoring, I'm search satisfying. They're using these words on shift in order to identify high-risk moments where the whole team needs to slow down and think about a patient a little differently. So the third piece of the puzzle is that we really focus this meeting on teaching the toggle. We focus the discussions on cognitive errors made. If the providers aren't there to go through their cognitive autopsy, we anonymize it and put it up to go through, so every case is talking about cognitive biases every single time. And then this one I can't overemphasize. This is probably the biggest shift in culture, and I think the root of why we're able to do all the things we're able to do with this process. And we really had to emphasize that this was a psychologically safe space to talk about your mistakes. I get it like a pit in my stomach every time someone emails me about a case that I screw up on, right? I think everyone can relate to that pit of your stomach feeling. However, I can tell you that after we start all of the meetings with this basic assumption, this is actually a SIM concept that I stole from the Harvard SIM Center, but I start every single meeting by saying this out loud, even though we said it out loud last month. We just say it again. And then I also I am empowered, and the other senior faculty in the room or people who have been on the committee for a while are empowered to call people out if they are not applying the basic assumption to the case we're reviewing. So if the discussion seems to be leaning towards maybe this person made a mistake because they were trying to hurt somebody, or that's the tone, we really bring it back to, we assume, and the assumption we're making is that everyone showed up to work to do a good job the day this happened, right? And something happened and they made a mistake. So this is the basic assumption. We repeat it every single time. So that is the last piece of our kind of peer review 2.0 puzzle. So just to review, we really open the meeting to all providers to make sure all boats are raised in the department. I can tell you that we have about 40 or 50 people at these meetings every single month. 2 hours of CME probably helps for our attending providers, but residents and APPs also seem to benefit from it. We focus on the 2 metacognitive theories that we talked about. Practice makes perfect, and we really focus on teaching the toggle via cognitive autopsy. And then this last one, I think, is this emphasizing psychological safety, I think is really proven by the fact that I can tell you over the last year, the majority of case reviews that we are doing have been self-referred before I can get to them via those other mechanisms. So we still do they still come through the chief review, they still come through past reports, but I usually know about them beforehand because the majority of our department now sees this meeting as a way to make sure mistakes are something we learn from and not something we just sit with. And I'll get emails from senior faculty saying, hey, I think I learned something from this case. I think other people could too. Or can you just see what other people would have done here? Because I'm not sure what I would have done. And I think that speaks to the biggest change in the psychological safety. All right. These are references and resources. That cognitive autopsy is on there, along with some other information about how we made this change. Does anybody have any questions? I have a couple more minutes. Carolyn.
Hi, Carolyn Holland, University of Florida. My question is, how do you pair this, or do you pair this, or do you also include M&M? Is that kind of integrated, or is it separate?
So yeah, that's a good question. So the M&M often happens before this, just based on like the monthly kind of cadence of things. So there are cases that have been at M&M prior to going to peer review. We usually try to make sure the M&M, the person presenting M&M, has access to the cognitive autopsies, so they can include that. We definitely use a lot of the same words in our M&M as we are. So they are linked, but not necessarily tied together, and that our M&M doesn't always include every peer review case, and every peer review case doesn't go through M&M. Yeah, but the screening process, and then we have made it an objective of our M&M to talk about cognitive errors made in M&M cases. So there's some dual teaching happening there. Good question. Anything else before I'm done? Yeah.
First of all, I wanted to say that's great, and
Thank you.
I'm so amazed that you guys do this. This is, I believe, it's so far ahead of the curve. I don't know if anybody here at any institution does anything like this. Nice. Good. I'm glad at least that someplace it's happening. I taught this for about 20 years, and never really got a lot of traction from faculty. And I think the fact that you've done this in a very blame-free and learning how to understand our cognition is really just amazing. It's wonderful. You're really,
Oh, thank you.
Congratulated.
Thanks.
Have you started doing any kind of data collection about what you're doing?
Yeah, that's a good question. The data collection that we have is mostly in the cognitive autopsy part of it, and looking at some of our research that we're looking at and haven't published yet is what are the most common cognitive biases named by both residents and attendings, and then trying to correlate those with some of the scoring that we have. Is there a cognitive bias that seems to be present in cases that are scored inappropriate more than others, with the attempt that maybe we should be teaching to that cognitive bias a little bit more. It's all self-reflection, so sometimes, I get these cognitive autopsies back once every 50 times, and it's just completely blank, and the person's like, I'm perfect, everything was great. Sorry, this sucked, but no, so it's not, you're relying on a lot of self-reflection, but we have 4 years of cognitive autopsies to analyze, and the corresponding kind of scoring and outcome cases, so.
And do you do fill out that data sheet in the meeting also?
So we do not. That's a good thought. We don't. We, on our peer review form, which is on that resources page that we turn in, and the staff office keeps, it does have a couple lines for which bias we think was present, but it's a minimal number of them. I developed that form, but the whole hospital uses it, and no one else is doing this work, so they didn't want to take up a lot of space on it for those bias yet. I'll get there, but not yet. Yeah, we're working on it. But I have a troubleshooting slide on the thing, but I think the biggest thing this took 4 or 5 years to change a culture, and every time we have a new group of humans, we have to kind of orient them to the process. So when I get people who haven't been raised in that system, it's a pretty big shocker to realize that you don't have to just murder a patient to go to peer review, but you actually, if there's anything to learn from, we take you to peer review. So, and that's a big culture change, and it takes a while. But
I assume you do that for near misses also.
Yes. Yep. Anything that we really ask ourselves, can somebody learn from this? And if the answer is yes, then it goes to peer review, which actually lightens that little feeling in your stomach, because as the peer review director, I probably go every 3 or 4 months. They're usually appropriate, but at least there's something to talk about, I think I could have done this a little bit better, that type of thing. Or I found myself really anchoring, I want to talk about that. Yeah. Any other questions? Okay. Thank you, everybody, for coming.